kind of symptoms as an epileptic fit, but they do not constitute an epileptic fit. So we have to find the appropriate diagnosis. Similarly, psychogenic hysterical seizures, they are so common in our population, and they often are treated like epilepsy. Definitely they are not going to respond. Then wrong drugs. Selection of appropriate drugs is very important in patients of epilepsy, and if you treat patients of myoclonic epilepsy with phenytoin sodium or carbamazepine, they are going to aggravate the seizures. So appropriate choice of drug for a particular seizure type is very important. Then wrong dose. If you are not treating by an appropriate dose, then obviously the response cannot be achieved. So we often see various prescriptions in which the dose is small and still the second line of drug is chosen. So unless you use appropriate therapy in appropriate dose, the drugs switching to another drug should happen only after you have failed to elicit response by an appropriate dose. Then various lifestyle issues like poor drug compliance, very common. Once you achieve seizure freedom, many patients fail to take appropriate therapy, or they stop the treatment on their own. Then there is a history of drug abuse, alcohol. All these substance abuse can trigger seizures despite treatment. Then sleep deprivation is an important provocation method, or triggering factor for seizure. So those who are on therapy, they have to be explained that they should sleep for at least 6 to 8 hours. Otherwise they can again trigger epilepsy. So how to approach the problem of drug resistance epilepsy? The most important that we have to educate the patient about their disease. They must be told what to expect from them, how we can ensure good patient drug compliance, what are the lifestyle methods that they should adopt in order to prevent seizure triggering. Then you have to review the diagnosis, whether the diagnosis is correct, whether the type of epilepsy you are thinking about is correct, whether the choice of drug is correct, whether you are using the drug in appropriate doses or not. You have to take appropriate account of what happens during the epileptic fit, whether it's a true seizure. So history taking is very important. Then video EEG now has arrived as a big tool by which we can monitor and evaluate these patients to know what is the type of epilepsy and whether it is corroborating with the electrical events that we see in an EEG. So video EEG is an important tool to evaluate these patients. Then if we follow the patients of any new onset epilepsy over 3 to 5 years, what we see is that if a person who comes with first seizure, if you treat, then there is a chance that they may not have any seizure in their lifetime, but there are 60% chance that if you don't treat these patients, they may continue to have recurrent seizures and they get converted into what is known as epilepsy. Now out of these early epileptic patients, if you add one drug, then there is a 65% chance that this single drug can help this patient from aborting the seizures, and then the seizures are well controlled. But then there are 35% of these patients who continue to develop seizures despite appropriate single drug, and then they convert into a chronic epileptic syndrome. Out of these chronic epilepsy patients, if we add another combination therapy appropriately chosen, then we are able to control in another 20% of this subgroup. But there could be a large percentage of patients who continue to have seizures, and these patients have drug resistant epilepsy. And how they can benefit? We can try various combinations therapy. Newer drugs have arrived which can be added, but there is still these patients, if they continue to have seizures, then they are a candidate for epilepsy surgery or newer treatment options like vagus nerve stimulation. Then over a period of years, the newer drugs, the first anti-epileptic drug arrived in 1859 when bromide was started being used as an anti-epileptic treatment, and the second drug arrived only in 1911, that was phenobarbital. So in between there was only one drug, bromide. Most of the patients were treated by bromide, and subsequently the conventional drugs arrived like phenobarbital, phenytoin, ethosuximide, primidone, benzodiazepine, sodium valproate, carbamazepine. These are the commonly used first line therapies which were gradually developed over the years, and there are large percentage of newer epilepsy anti-epileptic medications which are available, and many in the pipeline and would be available to us in the future. Now, general treatment principles, if we see, the target of treatment is primarily to control seizures and to ensure proper health of the patients, and how to achieve that is to use an appropriate drug which has minimum adverse effect and helps in the appropriate control of seizures. Then also you need to have a proper social integration of the patient, because social isolation of these patients because of the associated stigma is tremendous, and one has to ensure that the patient's education, caregivers should be educated that this is a simple disease which needs to be treated appropriately, and these patients can lead a normal life, and they should not stop the treatment suddenly or without advice, and no single drug can control all the seizures. So some of the patients will have to need a number of drugs, and various combinations may be tried, so they have to be in a regular follow. And once the seizures are controlled, at least after 2 to 3 years of the seizure control, the first attempt is made to gradually withdraw the medications by decreasing the dose. So abrupt stoppage of drug is never recommended, and it has to be adequately told to the patient and their family members. But it should be told to them that most of these patients can lead a very normal life like any other normal individual. So this has to be emphasized very clearly, that all these patients can have all normal activities, they can be employed, they can marry, they can have children. So and even after 1 year of good control, the licensing agencies have started giving driving licenses to them as well. Now I will try to discuss the treatment and sequence of approach to a patient of drug resistant epilepsy. Now any newly diagnosed epilepsy, the important thing is to choose the appropriate drug as a first line drug. So if we treat any epileptic syndrome with a first line of drug, the chances of success are good. So after the first anti-epileptic trial, if the patient continues to have seizure, the second drug is added, and gradually the first drug is withdrawn after the second drug appropriate dose is achieved. And if the second drug is able to control, we continue with the second drug. If we are not able to achieve the control of seizures, then a third drug can be tried, and the previous started drugs can be gradually withdrawn. So we can try 3 monotherapy trials. Now after 3 monotherapy trials, if we are not able to control the seizure, then we try the combination therapy. And combination therapy, we choose the drugs which are not interacting with each other and which have a broader spectrum of action, and then we combine these drugs and see whether the patient is able to control the seizures. And if we are not able to get this appropriate desired control, then we need to review the diagnosis by proper evaluation with video EEG monitoring, by which we be able to rule out various kinds of psychogenic or hysterical seizures or any non-epileptic movement disorders. Now if we think that this is an appropriate candidate for drug resistant epilepsy, that is they have failed the 2 combination appropriate drug trial, then we subject them to evaluation for epilepsy surgery, or those who are poor risk or those who refuse to have surgery, they can be a candidate of vagus nerve stimulation or various newer techniques which are still under evaluation, like various deep brain stimulation therapies. Importance is of rational therapy. Nowadays it is being advised or recommended that we should know how to combine the various kinds of anti-epileptic drugs, and to know how to combine, we should know what is the mechanism of various anti-epileptic drugs. There are various molecules as have been discussed by combining with various kinds of channels. So if we have sodium channel blockers, which include phenytoin sodium, carbamazepine, lamotrigine, oxcarbazepine and lacosamide. Then we have calcium channel blockers like ethosuximide, gabapentin and pregabalin. Then there are certain GABA agonists like barbiturates, benzodiazepine. Now if we combine the drugs which are acting on different substrates, then chances of success are more. If we combine 2 drugs or acting on in the same mechanism, then the chances of causing drug toxicity are known. So we have to combine drugs with different mechanism. Then there are other ways in which the drugs act, like synaptic vesicle protein 2A modulation. It's a new drug, levetiracetam, which has come up. It has a least drug interaction, so it's a good molecule. Then we have carbonic anhydrase inhibitor like acetazolamide. Then there are certain drugs which act on multiple sites, like sodium valproate, topiramate, zonisamide. So these are drugs which can be added in the second line therapy, and they can have a good synergistic effect. So how to combine these drugs? Can we have a guideline? It is said that you should start with the optimal dose of a one drug or a baseline drug, which is the most appropriate for that epileptic syndrome. Then add a drug which has multiple sites of action. Then your chances of combining a drug with multiple modes of action is there, and so the chances of better response is there. So but if by trying various kinds of combination, if you still are not able to achieve, then these are the patients who should be subjected to various kinds of palliative therapy, which includes epilepsy surgery. Then we should also take into consideration various comorbid conditions. Epilepsy patients can have other diseases also. So it's not that epilepsy is an individual disease. A person can have stroke, person can have diabetes, heart disease, hypertension, asthma, Alzheimer. So epilepsy patients can have all kinds of disease. So if there are comorbid conditions in the same patient, we have to find out which is the appropriate drug which cannot aggravate the comorbid conditions. So in order to choose any combination therapy, we should know the comorbid conditions. What could be the goal in epilepsy management? Obviously, seizure freedom is the most desired goal with the minimum side effects, and the drugs chosen should not interact with each other. There are many enzyme inducers in anti-epileptic treatment therapies like phenytoin and carbamazepine, which can interact and decrease the level of other drugs. So we have to combine drugs which do not interact in such a way that they can alter the levels of the other drug. So if a patient has comorbid heart disease, then what should you avoid? Well, there are certain drugs, as I have told you, that carbamazepine, phenytoin and phenobarbital. These are the enzyme inducers. They stimulate the hepatic microsomal enzymes, and as a result they increase the clearance of the various drugs like antihypertensives. Now if a patient has heart disease, he is using various antihypertensive, you add carbamazepine. Now it stimulates the metabolism of antihypertensive. As a result, patient continues to have uncontrolled blood pressure. So that's an important thing that you must know, that if a person has hypertension, you should avoid giving drugs which are enzyme inducers and which can increase or decrease the level of co-prescribed drugs. Similarly, in patients of lung disease like chronic obstructive pulmonary disease or interstitial lung disease, we should avoid sedative drugs like clobazam, like carbamazepine, like phenobarbital, like all the benzodiazepines, because they can cause respiratory depression. So these are the drugs which you have to avoid. Similarly, in hepatic impairment, those who have chronic liver disease, you should avoid potentially hepatotoxic drugs and also sedative drugs. So valproic acid and phenytoin sodium, carbamazepine, they are all potentially hepatotoxic drugs. So they should be considered only if the primary or more safer drugs are not having desired effect. So what we do in chronic liver disease, we usually prefer either topiramate or levetiracetam over the other drugs.